Ladies and gentlemen, we now move into a focused clinical keynote, one that addresses a challenge that affects a large and growing number of fertility patients and often leaves them with more questions than answers: low egg count. This condition, often misunderstood and poorly communicated, has major emotional, biological, and financial consequences for patients. But science today offers us a spectrum of viable pathways, from advanced simulation protocols to donor programs to embryo pooling and beyond. And who better to guide us through this landscape than Dr. Gunjan Gupta? Dr. Gunjan Gupta is the founder and director of Gunjan IVF World, a pioneering fertility chain that has impacted thousands of families across India. Known for her transparent communication and sharp clinical acumen, she combines compassion with precision. With centers that serve both urban and semi urban communities, Dr. Gunjan is at the front line of India's fertility dialogue, especially when it comes to tackling low ovarian reserve and premature ovarian aging. Please join me in welcoming Dr. Gunjan Gupta as she speaks on low egg count, exploring viable pathways. Over to you, ma'am.
Thank you. Good afternoon, everyone. So it is a moment of pride for me and all IVF fraternity to celebrate this day. So it's a pleasure to be here, and I want to thank the team IHW for organizing this event and giving us all a chance to come and speak from the platform. So good morning, everyone. So here we are. We know we are tackling with everything which is low in this world, whether it is low eggs, it is low sperms, it is less IVF centers, it is less finance. So it is a world of low, I feel sometimes. But yes, we need to start thinking positively. उसी में से उन्हीं तिलों में से ही तेल निकालना होगा is the strategy today. Kyunki we have to understand the woman of today. You can't tell her you get a donor egg. It's so difficult, you know. Recently my embryologist said, "Ma'am, you always give me 1 egg, 2 egg, 3 egg, और फिर आप कहते हो pregnancy करनी है. How is it possible?" Bhupen, his name is Bhupen. I said, समझ जा, भाई तुझे eggs भी इतने ही मिलने वाले हैं और कुछ ज़माने में sperms भी इतने ही मिलने वाले हैं, and we have to give a pregnancy if we want to really do good ethical work and respond to the women of today and tomorrow. Where do you think the Gen Zs and the millennials and they are going to head? Things would be to the So where are the Gen Zs and the millennials going to go? We don't know actually. I have a young daughter and she says, "Mom, don't even think about it." Though I am trying to feed again and again. No, 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 no. Marriage has to be on time. Shadi has to be on time. Bacha has to be on time. But they are a different world. So we will, and you can sort of talk to one person, but what about the rest of the world? So yes, low egg count and exploring viable pathways. I am Dr. Gunjan, so I don't think there's much there. What I want to start is that as far as Gunjan IVF World is concerned, a little about things. We started in 2016. So IVF, I came into IVF, you can say industry or IVF as a field since 2016. Before that, I was practicing as a laparoscopic surgeon. I have been trained from KGMC and UK, and I was not really interested. But when I was doing laparoscopies, I realized that you reach an end result when you can't give them a baby, and that is where I started. But yes, we have been very lucky with that, that already we have worked a lot on innovations and technology. So we already have two posters which we have presented in ESHRE over the past years, and this year I'm really feel proud to share, because it is for our entire fraternity, that 2 of our papers have been accepted at ASRM. And as I had heard Keshav talking about AI, So that this is actually an AI dose calculator which we have made on the basis of BMI, AMH, AFC, and it has been done by my daughter who is an engineer, and on a regression analysis we have already done. So this is how we can scale. You know, the best part of this is what is the use of this paper. The use of this paper is for scaling, because you fill in these parameters, it will give you a dose for 10 or 11 days, because we have put a capping at 11 days of stimulation max, and it gives you a dose based on HMG and FSH, and it is really, really effective. So you don't need to do so many scans, you just need an AFC on day 2. And of course we are doing trial of this test, so soon, maybe a year later, we'll have better things, we'll maybe doing some modifications also, but this is how we begin. And of course another poster which I have written has been accepted, that is based on tuberculosis, about the Indian multicentric study. We need to understand that this is also something which is important. Nobody internationally talks about tuberculosis, which is rampant in our country and a major cause of infertility. So of course this I will skip this journey. I started in 2016, and now we have 4 centers and 5 OPD centers, and we've been very, very lucky being awarded so many times, and both by Foxy and other bodies like Times of India, etc. So basically exploring viable pathways. So I will begin. What do you think the being healthy is? Many people will say disease free, but is there anybody can say, sitting in this whole place, that he has never been diseased, बीमारी हुए ही नहीं, ऐसा नहीं होता है. So basically health is not an absence of disease, but it is the ability to rejuvenate ourselves, to grow, springboard from every adverse situation and rejuvenate yourself. So it is rejuvenation which is being healthy, and that is what is the woman of today. Of course, we have a lot of celebrities who have been rejuvenating themselves. So we can rejuvenate our skin, we can rejuvenate our hair. Why not the poor ovary? Why should we leave her behind? So that is why we have to understand that aging is a rule, and declining ovarian reserve is also a rule which every woman has to understand. We are all aware of this. I have a very learned audience sitting in front of me about how the primordial and the primary follicles, and then it is the preantral and the antral follicles which are sensitive to FSH, and that is how they are follicles which are recruited, and once they get recruited, and then they develop, and then there is final ovulation. Of course, ovarian reserve, when we talk about, we are dealing with 2 things. One is the quantity, and other is the quality of the reserve. So as the women age, they have fewer eggs, poor egg quality, increased chances of miscarriages. But the most important thing what we need to understand is, after 35, 1/3 of the women will have a difficulty in conceiving a baby. This is the message which we need to give to our people when they are delaying the pregnancy. Of course, we are aware of what these tests are. It is how do you assess the reserve, by means of AMH, AFC and age. So what I include in my counseling nowadays is what everybody needs to understand, which is the first organ to age in a human body. Do we talk like this? It is the ovary. After 38 ages, do we ever think about it that way? No, but it is a fact. So this is a statement which I have started making a part of my counseling ever since I sort of really hit on this fact like this. Of course, there are a lot of other variables associated, genetic, health, causes of infertility, years, nutrition, which leads to a low reserve. And influence of age we are aware of. It is mitochondrial function, granulosa cell apoptosis, and oxidative stress which leads to. Influence of age we know as the number of oocyte which is retrieved from a younger person. If it less than 30, if it is around 15, it is less than 5 the moment she touches more than 40. And also the aneuploidy rates increases, we are aware of that. So how does it, sorry. So basically the most important part of this slide is, we all know is that when it is 6 oocytes which will give us a euploid embryo, above 40 it is the 16 oocytes. And where are the 16 oocytes? Who will give us those 16 oocytes at the age of 40, 41? Poseidon criteria age related, so it is not only the age but and the AMH which affect, but it is a multiplicity of factors, and that helps us to define the Poseidon criteria, which helps us making the decision. So what can we do? We have talked about how to assess, how do we know, how do we do, but how do we do, what do we do when we are stuck with? There are few things which are new, few things which are experimental. So basically these are the pathways which we need to do. So basically ovarian rejuvenation with PRP and stem cell, which is coming in a new way. Here what do we do? PRP, we know it is autologous, it is made from your blood, it can be injected inside the ovaries, and it, since it is a set of growth factors, it helps to rejuvenate the eggs, and it can be offered to women theoretically under 50, but of course I would say somewhere around 40, 42 we should take as a benchmark. Infertile women, women with premature ovarian failure and premature ovarian insufficiency. I am doing personally a lot of work on this thing, on ovarian rejuvenation with PRP. And what we also do at times, it we give GCSF, which improves the harvest of PRP, I can say. So it is injected directly into the ovaries, releases the growth factors and stimulates the endogenous stem cells to differentiate into eggs. Technique is very simple. We have lot of now kits available in the market which can be directly used. Initially we started by doing entire centrifugation ourselves and separating the plasma, but now there are kits which come with gel and they can be done. This is a video how the PRP is made. So this was of the video of the subendometrial injection, basically hysteroscopic, but what we are doing again is a OPU needle which we are using for vaginal instillation. And this is how the ovarian PRP procedure is performed. It's a simple technique. Somebody who is doing OPU, it is not a big deal at all. The moment we inject, we'll see a white splash which is very easily visible. So basically what I like to here give a word of caution for the ovarian PRP procedure is that a lot of young people are sitting. It is not easy as a pickup, reason being the ovary is much smaller, very firm. Sometimes when you are going in, you have to be very, very careful because you are doing it ultrasonologically. The major vessels are on the side, so you should never overshoot with the needle. Of course, there is evidence which says that preliminary evidences show that it may be of limited benefit, but of course, when we are left with nothing, it is better we can offer to the patient, but definitely tell the patient that this is also under study. The patient should be aware. And as Cochrane has said that the information is insufficient, so further studies are needed. Stem cell works on the similar principles, just it is more invasive because to extract stem cells, we have to do two procedures, give general because it's the iliac crest which is involved. So personally, I have more experience with giving ovarian PRP. Now there is a new thing around the corner, which is the role of exosomes. Exosomes play a significant role in ovarian aging, and by acting as a communication vehicles in between the cells, what has been found that exosomes help to rejuvenate the ovaries very well as well. There are preparations which are available in the market, not available in India. I've been trying, I did a lot of chat GPT as well to get the exosomes. I left a message with Nath Brothers also, but somehow I did not get it. But I know something is available. There is, I spoke to somebody in South America as well. She was preparing it herself. I couldn't really get a hang on that. So, but yes, it seems to be very, very useful. And the best part is that exosomes also is found a lot in follicular fluid. So that means it is important, it can directly interact with the granulosa cells and the oocyte, impacting their development and survival. So basically, I don't know, it seems very far-fetched, but maybe the follicular fluid can be used to extract the exosomes as well. It is like a food for thought, which I feel people should think about it. And there are a lot of pharma people inside, they can use their R&D division to come with something like this. So it is something, this is how exosomes
are
work.
tiny nanoparticle
This is the principle of
that
exosomes.
facilitate cell-to-cell communication. Exosomes are created by inward budding of endosomes and then secreted out of the cell membrane. Exosomes carry with them cargo, including proteins and nucleic acids, which they deliver to other cells, a bit like a message in a bottle. Once delivered, the cargo affects how the recipient cell behaves.
So this was about exosomes. So what's next? Yeah, this is another very interesting paper which I happened to just surf along. So this was an article in Forbes, and what is it? It says that AMH is a hormone which inhibits the recruitment of follicles. So they feel that if they give the woman AMH, maybe they will be able to delay menopause. Wow. So, and actually Oviva Therapeutics is working on it. There was this article which has come in Forbes, so we may get to hear something like this, because every month the fact is that about 1,000 eggs are recruited and only one goes for ovulation. So what a waste of the eggs, and what a waste of the hormones. So if we have something like this, they might be there. And lastly, what is the most important, another thing which is like when we are exploring the ways, the Hippo pathway. I remember when I was doing medicine, there was nothing like that I remembered of studying the Hippo pathway, because the entire study has been done over the last 20 years. So basically, what they are saying, that Hippo signaling pathway, it maintains primordial follicles in dormancy. Basically what it does, it's a very interesting pathway. What it does, it is the one which is responsible for what will be the size of growth of the organs, how will they develop, how will they not develop, koi ovary itni badi hogi, itne eggs honge, or any other organ, what will be the size of it. So basically it is the controlling, the size controller and the functional controller is the pathway. So what we do, if we disrupt the pathway, maybe we can activate the dormant follicles and their growth. So what they started doing, IVA, is in vitro activation. What they did was, laparoscopically, they cut a segment of ovarian cortex, they brought it out. Initially, they kept it in vivo with AKT stimulators, and then 2 days later, they did another laparoscopy and reinserted it either in the same ovary, contralateral ovary, or near the fallopian tube. Now is the time when they have already modified on that, and now they are doing a drug-free IVA. What is drug-free IVA? They are doing one sitting laparoscopically. You take the ovarian cortex, a part of the ovarian cortex out, cut it into small pieces of 1 mm, and then re-inject it in the contralateral ovary or in the same ovary. And it is supposedly giving very good results, because already we have a 2-year data on that from 23 to 25. We say 26% of the women showed follicular growth, 36% approximately were pregnancy rate among poor responders, and 21% actually had a live birth rate. For 2-year data, I think it is amazing. So there is something which we need to do about it. Maybe we should also start talking, discussing, and so how to go about it. So this was the major thing. Of course, then rest is laboratory options, ICSI for all, PGT-all, ovarian pooling, we are all aware of. We are already doing that. Role of adjuvants, we are all aware of all the adjuvants which are there, androgens, DHEA, testosterone, then growth hormone, then antioxidants, coenzyme Q10, melatonin, luteal stage pre-treatment, and during stimulation you can give recombinant LH. So this was all about the adjuvants. The data has been limited. DHEA, they say it may help in poor responders. Testosterone, they may help in poor responders, but we know about the T-transport trial which said it was not effective. But yes, we all do use testosterone, because even Polizos feels that he did not use the adequate dose of that. Pre-treatment antioxidants, they are something which are low-hanging fruits which we do keep on using them. But of course, it is empirical, and again, there is melatonin, which is another antioxidants. So this was about what we can do in a woman of low reserve. So now what we can do for the younger generation? We need to maybe educate them. This is a time for education. Like we started educating about cervical cancer screening and vaccination. Now majority of the girls get it done. So this is a small
Priyanka
video.
Chopra Jonas had her first baby at 40 without even getting pregnant. How is that possible? Is having a baby at 45 the new 25? Well, with egg freezing, it just might be. We already know what is egg freezing, but a lot of times we have a lot of questions as what if I become infertile after it? What are the side effects? What if I'm not married? What if I'm not sexually active? Well, to answer all of these questions, let's speak to Dr. Gunjan.
Well, even if you're not sexually active or unmarried, it can be done, because it is done by a fine needle using an ultrasound, which is just like using a tampon. Also, this procedure does not lead to infertility for sure, because we are using the eggs which would have been otherwise destroyed, as I mentioned in my previous video as well. So if required, it is safe to go ahead.
Well, that is reassuring, but I am wondering, when is the right time to start egg freezing? How long can my eggs be frozen for?
Well, it goes without saying, the younger you are, the better is the egg quality. Best age I would rate as 25 to 30 years, though you can freeze it 35, 37, any age when you realize it. Also, how long can it be frozen? Very interesting, because there is no upper limit to it. You can freeze it for 10 years, 15 years. So majority of the time it is frozen between 5 to 10 years.
So guys, that's a wrap on all things.
So this was an educational video which I had created with my daughter. So this was it. So of course we are aware it is the race against time, and that is why I have written a book also on egg freezing, and it will be my pleasure if I can have all the seniors coming with me for that. So this is our success rates. Basically, one success rate is low AMH cases. This was last year data, and what we see, even in 0 to 0.5 and 0.5 to 1, we have a success rate averaged out around 65%. What I'm trying to say is that we should not just shy away if a woman comes with low reserve and offer donor eggs to her. Of course, here I just want to give a background, because there are a lot of students here, that we have a gift academy and we are training youngsters in various programs, and if they want, they can join our fellowship program. IFS has also helped us to be a part of their academy as well. The amity exam is being held on 27th, so you can give the exam for that and choose the centers to your choice. So I think thank you. That is all, and thanks everybody for your patient hearing.
Thank you, Dr. Gunjan, for that interesting presentation. For the launch of the book, may I please invite Mr. Kamal Narayan, Mr. Narendra Malhotra, Mr. Jaideep Malhotra, Dr. Pankaj Talwar, Dr. Indrani Lod, and Dr. Professor Shweta Mittal Gupta on the stage. Dr. Jaideep Malhotra as well, please. Yeah, please. Can we please have a huge round of applause as we launch the book? Let's keep the applause going, ladies and gentlemen. Thank you. Thank you, everyone.